طيب السلام عليكم. Welcome everyone to our lecture before last in our great initiative Unity through Knowledge, which was a collaboration, which is a collaboration between Sudanese Association, Sudanese Doctors Association in Qatar, SUDAق, and Anesthesia, the Sudanese Anesthesia Board. Today, again, we will have Dr. Osman Al-Selmi with us, and he will go through drugs that has huge impact in our perioperative management. I'm not gonna keep you longer, so today we will have a session on antiarrhythmic drugs and anticoagulant medications. Without any further ado, I'll just leave the stage now to Dr. Osman Al-Selmi. Welcome, Dr. Osman.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. Thank you, Dr. Hayat. Thanks, Dr. Khalid. And thank you to the Sudanese Doctor Association in Qatar. Welcome, everybody. I hope that you are all well. ونسأل الله أن يفرج عن أهلنا في جميع أنحاء السودان وتكونوا كلكم بخير بإذن الله. So again, today we have a lecture on pharmacology. This is a kind of a basic knowledge, but that's kind of very, very important for you to know for those who are doing their exams, as well as for those who are want to integrate these in their clinical practice. It's kind of a pharmacology, but kind of mixed with some clinical sense, but I would say that it's just a highlight, really. So you really need to read more about this one to have a full knowledge of these very important drugs which you encounter in a daily basis in your clinical practice. I would say that I have no conflict of interest with this presentation as purely for educational purposes. The objective by the end of this tutorial, I hope you will be able to describe the normal electrophysiology of the heart. You will be able to recall the mechanism of action of most of the antiarrhythmic drugs, not all of them, but we will highlight probably one drug of each category. You will be as well able to discuss the modified Singh-Vaughan William classification and the limitation associated with that one. And we will have further update on this classification, and we will link it to clinical practice. On the other part of the tutorial, you will be able to identify the physiology and the key components of homeostasis, and you will be as well able to describe how antiplatelets and anticoagulant affect the coagulation and it affects the perioperative care of our patients. The most important point I want to mention is that we will have a few slides about the physiology of the electrophysiology of the heart, as well as the homeostasis of the blood, because this is very integral to your understanding of how those drugs work and how you management and manipulate them in the perioperative care of patients. So the action potential is something very important. You need to know about it in and out, the physiology behind it, the phases of the action potential, because when we come to the drugs will be linked to the phases of the action potential. Probably this something you know about it very well, but just to remind you that the sodium-potassium ATPase bump, it moves sodium ions, 3 sodium ions out and 2 potassium ions in. This is kind of very basic, but it's very integral for you to know about those drugs. So the sodium-potassium ATPase maintain the resting membrane potential. And the resting membrane potential will generate a negative electrical potential inside the cell and maintain high intracellular concentration of potassium and high extracellular concentration of sodium. So the sodium-potassium ATPase act against the concentration gradient of these two very important cations. So when the action potential starts, so the action potential of the normal cardiac muscle, the one you see on the left side of the graph, is usually maintained at around minus 90 millivolts. And that is, as I said, the function of the sodium-potassium ATPase plus the high permeability of the of the cell to the potassium. So once the threshold potential reach, then depolarization occur. And that for the cardiac muscles, it happened at around when the interior became around plus 30 millivolt. So at that time, voltage-gated sodium channel will open and a rapid inflow of sodium occurs. That will take you to phase 0 of the action potential. The nodes which you can see and it's marked as number 1, this is phase 1, and this is when potassium ions open, creating an outward potassium currents and forming a notch. Then the plateau phase, which is phase 2, and that is mainly a balance of inward calcium and outward potassium. And then phase 3, the repolarization, when the action potential come back to the resting membrane potential phase 4. Two important terminologies are very important to know, and these are the absolute refractory period and the relative refractory period. So these are the interval between the beginning of the action potential and when the cell can generate another action potential. This time is called as the absolute refractory period. So where the cell membrane cannot be depolarized at this stage. At the end of that one, until the end of the repolarization phase 3, this is a relative refractory period. And during that time, the cell could be depolarized, but it needs a stimulus which is kind of more than the normal amount that trigger action potential. So it needs a higher than normal depolarization potential. This is mainly applied to the cardiac muscle. When it comes to the SA node and AV node action potential, there is a small difference, which is the resting membrane potential, which is stand at minus 50 or minus 60 millivolt. At that time, voltage-gated T-type and L-type calcium channel open, and they bring the membrane to the threshold potential. And the repolarization occur by the inactivation of the calcium and opening of the delayed calcium channel. You will see this is kind of very basic and very confusing, but I know that you know about it. It's just to remind you, because we will relate the antiarrhythmic drugs to those phase of the action potential. So what is the mechanism of the arrhythmogenesis? So this is again a very important concept, and that the mechanism of how those arrhythmia happen. Usually there is a disturbance in the impulse generation and coordination. So it gives you either bradycardia or bradyarrhythmia or tachyarrhythmia. Bradyarrhythmia usually occur due to failure of impulse generation between the sinoatrial node or failure of the action potential propagation from the atria to the AV node and the ventricle through the Purkinje conduction system. So the bradyarrhythmia are kind of more straightforward. Is because the automaticity of the sinoatrial node and the propagation of the action potential from the SA node to the AV node and the Purkinje system will be blocked somewhere, and that will give you bradyarrhythmia. While the tachyarrhythmia, there is kind of 3 distinct mechanisms around the tachyarrhythmia. They are either there will be enhanced automaticity or trigger automaticity or re-entry tachycardia. For the enhanced automaticity, it refers to a rapid regular heartbeat. This will be originating from the actual beat generator, which is the sinoatrial node. And that is usually we will refer to as sinus tachycardia. The enhanced normal automaticity occur with beta adrenergic or vagolytic stimulation. Okay, because the beta 1 receptors, they are in the heart, and when stimulated, they give you tachycardia. While the vagolytic stimulation, when you block the vagal stimulation to the heart, then again there will be a dominant sympathetic stimulation, and it will give you tachycardia. Whereas the enhanced abnormal automaticity will refer to a situation where the heartbeat originates from sites other than the sinoatrial nodes. And the triggered arrhythmias occur or describe the occurrence of premature action potential. This will occur just before the previous beat is complete. So before the full action potential complete, another beat will be originated and they will overlap. So this is we refer to as a triggered arrhythmia. The re-entry, as you can see in the graph, so in the B side, the normal conduction, you can see the direction of the arrow. And then in the presence of region where the conduction is slowed, then an antegrade conduction is blocked from insufficient sodium channel recovery. So the sodium channel not recovered yet to accommodate the next action potential. So there will be kind of a blockage or a delay in the propagation of the action potential. And for that reason, the retrograde conduction occur when it reached the downstream, causing a re-entry. So this is they refer to as a re-entry tachycardia. This is all, as again I said, important because it will come when you refer the antiarrhythmic medication. So we know now the kind of the arrhythmogenesis, how it originates based on the action potential. So now, if you want to treat those tachyarrhythmia or bradyarrhythmia, then you have to follow the principle of antiarrhythmic medication. So what the antiarrhythmic medication we give, they do, they suppress the enhanced pacemaker activity, or they prevent the trigger automaticity, and they modify the conduction and refractoriness to prevent re-entry. So the same mechanism, but they just pharmacologically, they interfere with those mechanisms to modify them and then take the whole action potential to normal sinus rhythm. So when we come to the suppression of the enhanced automaticity, there will be kind of four things which they do to accomplish that task of when they go and they suppress the enhanced automaticity. So either they hyperpolarize the resting membrane potential, and by that they delay the upcoming depolarization, or they reduce the slope of the pacemaker potential, mainly phase 4. Okay, you can see in the graph. So between A and B, okay, so they increase the hyperpolarization of the resting membrane potential. So they delay the upcoming depolarization. They reduce the slope, so the depolarization peak or threshold will be less, and they increase the threshold potential. So when they increase the threshold potential, they will require more time for the cell to start the depolarization. So we remember we said that it is at minus 90 and minus 60 for the sinoatrial node when the threshold potential is reached. So those medication, when they suppress the enhanced automaticity, they increase the threshold. So it will be higher than normal. Or they can also increase the action potential duration. So they increase the refractoriness of the pacemaker cells. Okay, so this is kind of just more to explain about the inhibition of the trigger activity. So a trigger activity that occur near to the very end of repolarization. So at the end of repolarization, there will be an activity, and that will refer to as delayed after depolarization. And that's mainly could be prevented by reducing the intracellular calcium via reducing the calcium channel, both the L type and the T type. And that could be accomplished by using calcium channel blockers or class 2 activity like beta blockers. And this will decrease mainly the activity of the sodium calcium exchanger. Early after depolarization, another concept, and it is associated with a prolonged action potential um, because it prevents by shortening the action potential duration. So this again will be accomplished by beta blockers or calcium channel blockers. Inhibition of re-entry, that's kind of, again, very important. You remember that we say that the re-entry is due to a slow transmission of the impulse. So the impulse will follow a retrograde pathway to reach the target. So this will be accomplished either by prolong the effective refractory period. You remember the duration from the start of the plateau until the end of the repolarization. We said this period is an absolute refractory period. So when you prolong the absolute refractory period, that will reduce the tachyarrhythmia. And that is mainly will be accomplished by when you block the sodium channel, and this will be accomplished by class 1A and 1C sodium channel blockers. You could also accelerate the conduction through the region of slow conduction. It's mainly by antiarrhythmic like lidocaine, because the lidocaine dissociates quickly after inactivating the sodium channel. Okay, a major kind of advancement in the development of the antiarrhythmic drugs is the von Willebrand classification. And this is what you can see in the screen. This is the traditional von Willebrand classification of antiarrhythmic drugs. So those drugs has been classified into 4 classes: class 1, 2, 3, and 4. Okay, and you can remember it's just class 1 is sodium channel blockers, class 2 is beta blockers, class 3 potassium blockers, and class 4 is calcium channel blockers. This is very important, especially for those who are doing the exam. It's an area usually of questions. Again, the sodium channel blockers, class 1, has been divided into 3 classes, A and B and C. And this is mainly based on the shortening of the refractory period. So class 1A, they prolong the refractory period of the cardiac muscle. And this example will be like quinidine, procainamide. And class 1B, sodium channel, they shorten the refractory period of cardiac muscle. And this will be things like lidocaine and phenytoin. And when they have no effect on the refractory period, like flecainide, this will fit into class 1C. Class 2, as I said, is beta blockers, and this is things like esmolol and atenolol. And class C is potassium channel blockers, is the amiodarone. And class 4 is the calcium channel blockers like verapamil. I have to say that von Willebrand classification has been criticized because it does not include drugs like digoxin or adenosine. Individual agents also, they don't fit neatly in the category. Like, say, for example, sotalol. which is a beta blocker, class 3 drug, but again, it fit in class 1 and 2. So there is a limitation to the Vaughan William classification. Singh has attempted to modify the Vaughan William classification to include more drugs. And as you can see, if it is clear, I know the writing is very small. However, it is a kind of the same concept, but it is kind of expanded to accommodate more drugs. As you can see, there is an addition of class 0, and then class 1 remain the same, while class 2, rather than just beta blockers, it has been renamed as autonomic modulator to include beta blockers and then include the muscarinic blockers and muscarinic agonists like the digoxin and adenosine, which act at adenosine receptors. The rest also kind of remain the same in terms of potassium channel blockers and calcium channel blockers. So it's kind of an attempt to modify the Vaughan William classification to accommodate more drugs. Another classification, which is probably more practical, is to classify those drugs according to what we use them for. Okay. And if you look to the tachyarrhythmia, you have either supraventricular tachycardia, or you have ventricular tachycardia, or you have drugs which work on both of them. The commonest drug which used for SVT, like digoxin, adenosine, verapamil, beta blockers, and quinidine, while ventricular tachycardia, we usually use lidocaine, mixilitine, and then some drugs which we use them for both SVT and VT, and the commonest will be in this category is amiodarone. And then for digoxin toxicity, we usually use phenytoin. Just a quick wrap up of some of the medication which kind of fit into the classification or the modified classification, like the addition of class 0, and this is fit into hyperpolarization activated cyclic nucleotide gated channel. And this is kind of a recently approved drug for clinical use. It has a negative chronotropic action, but it doesn't have hemodynamic effects, and it's kind of useful in patients with impaired cardiac function who have suboptimal heart rate control despite treatment of beta blockers, i.e., you cannot add more beta blockers or increase the dose for the fear that they might have some hemodynamic compromise. So you can add ivabradine to control the heart rate and maintain the cardiovascular or hemodynamic parameters. And it's only available in oral formulation. The class 1 medications are the sodium channel blockers, and these among the commonest usually we use. And they are effective in treatment of SVT, atrial fibrillation, ventricular tachycardia, especially related to re-entry tachycardia. And most of them, they cause hemodynamic instability. Class 1A is things like quinidine and procainamide. And they, as you can see, they reduce the slope of phase 0 during the depolarization phase. Class 1B, they bind quinidine and procainamide usually attach or bind to the open sodium channel. Okay, while class 1B, they bind to the inactivated sodium channel. However, they dissociate rapidly from the receptor, allow time for the next cycle of action potential. So the conduction will be accelerated, and this is good in re-entry tachycardia. Class 1C, they again bind to the inactivated sodium channel. However, they dissociate very slowly, and this leads to channel blockage, and the conduction is reduced. And this is the example in this category is flecainide. And flecainide has been used in many of the kind of tachyarrhythmia, like ventricular tachycardia, especially, as I said, attributed to re-entry atrial fibrillation, VVC. It is particularly useful for treating paroxysmal atrial fibrillation. And it is also, the good thing about it is available in IV and oral formulation. When we come to the autonomic modulator, the beta adrenergic receptor stand out, and they block both beta 1 and beta 2 receptors, and that's why they cause probably lots of side effects, and side effects usually be mediated by blocking the beta 2 receptors, especially things like bronchospasm, fatigue, peripheral vascular symptoms. So these are the non-selective beta receptor antagonist. Some of them are selective, like metoprolol, bisoprolol, and atenolol. Esbolol is an ultra-short selective beta-1 blocker. Usually we use it in the intraoperative period because it kind of acts fast and dissociate fast, so you can use it for quicker control of the heart rate. Propranolol is a non-selective beta blocker, but the good thing about propranolol, it has class 1 activity at high dose, and this will contribute to its antiarrhythmic effect. That's why we use it in things like thyrotoxicosis and this to prevent against tachyarrhythmia. Another example of the autonomic mediators is the muscarinic receptor blockers, and these are the atropine and glycopyrrolate. Obviously, you will be aware of those drugs, which we use commonly in the intraoperative period. They block the muscarinic receptors, so we use them for bradyarrhythmias. Adenosine, one of the most important drugs, antiarrhythmic. It is naturally occurring purine nucleotide. It's a colorless in vials containing around 3 mg per ml. It's highly effective in terminating atrial re-entry tachycardia. The effects of adenosine are very short-lived. It's very short, with an elimination half-life of around 10 seconds because it is broken rapidly into the red blood cells. Okay, and what adenosine does, it does open the sensitive potassium channel, causing hyperpolarization, and it has a negative chronotropic effect within the AV node. We usually use adenosine to differentiate between supraventricular tachycardia and ventricular tachycardia. So if it is SVT, then the rate will be slowed, while if it is VT, it will not affect the rate. Atrial fibrillation and flutter are not converted to sinus rhythm, as they are generated by a re-entry circuit. So adenosine doesn't really help with those ones. Adenosine as well has side effects, which include chest discomfort, shortness of breath, and facial flushing. If you kind of talk to somebody who had adenosine before, he will typically say those kind of symptoms. It's kind of sometimes they call it as impending doom. So a part of autonomic modulator as well is the M2 receptor activator, digoxin. It is a very common drug. It's a glycoside, and it is extracted from leaves of digitalis. What digoxin does, it inhibits the cardiac sodium potassium ATPase, and as such, it leads to increased intracellular sodium and decrease intracellular potassium. So once you hear it increase the intracellular sodium, then this will uh, uh, go into the sodium calcium exchanger. So it will lead to an increased exchange with extracellular calcium. So more calcium will be inside the cell, and this will increase the intracellular calcium, and this will have a positive inotropic effect. So this is very well known about the digoxin. The other thing about the digoxin is the refractory period of the AV node and the bundle of his is increased and the conductivity is reduced. Okay, so it positive inotropic effects and it slows down the heart rate. The other thing is block the release, it potentiate the release of acetylcholine at the cardiac muscarinic receptor. And this is again help in slowing down the conduction. The digoxin has been historically said to be avoided in patients with pre-excitation like WBW, as the AV conduction can enable conduction by an accessory pathway leading to ventricular fibrillation. So this is one of the things you need to be vigilant about it. The digoxin has been traditionally used in atrial fibrillation and atrial flutter. It has a low therapeutic ratio. Usually we load with 1 to 1.5 mg in over 24 hours, and then we follow biomaintenance dose. The oral bioavailability is greater than 70%, which is good, and it's about 25% plasma protein bound. It has a volume of distribution of around 5 to 10 liter per kg. And concentration exceeding 2.5 microgram per liter is usually associated with toxicity and ventricular arrhythmia treated with lidocaine or phenytoin. So if the digoxin toxicity is evident, then you will definitely have some ventricular arrhythmia. But if the plasma level present above 20 microgram per liter, there will be a life-threatening arrhythmia, or hyperkalemia will become uncontrolled. So the digoxin is kind of a very important drug, and we should really know much about it. So we'll move on to the potassium channel blocker. So this is class 3 in the von Willebrand classification. And the best example here is the amiodarone. And the amiodarone is presented as tablets containing 100 to 200 mg and a solution containing 150 mg per ampule. And you usually dilute in 5% dextrose. It can be used for treatment of SVT, VT, WBW. So amiodarone really is your friend whenever you have arrhythmia, then you can sure start with amiodarone. You can usually give a loading dose of 5 mg per kg over 1 hour, and this will be followed by 15 milligram per kg over the next 24 hours. So usually we give 300 mg in the first hour, and followed by an infusion of 900 mg over the next 24 hours. Amiodarone block potassium channel. It slows the rate of repolarization and increase the duration of action, potential, and refractory period. So it slows down the conduction and the heart rate. It has a 50 to 70% oral bioavailability. It is highly protein bound, and it has a long elimination life. It has been said that it's excreted by the lacrimal gland, skin, biliary tract. It has some adverse events. It's usually the perioperative period will be limited to cardiovascular system. It can include vasodilation and myocardial depression. As well, this has been linked to atropine-resistant bradycardia and tissue. Some effects is associated to its tissue deposition, such as pulmonary fibrosis and hepatic dysfunction, has been also described. The calcium channel blockers, class 4, they prevent the influx of calcium through the L-type channel in the SA node and AV node as well. They being used for SVT, atrial fibrillation, flutter, prophylaxis of angina, as well as treatment of hypertension. They depress the automaticity and they decrease the conduction. They are orally and intravenously. They have high phase pass metabolism, so this will depress their oral bioavailability to around 25%. They are highly protein bound and they are metabolized in the liver to inactive metabolites. So if usually used to treat SVT complicating WVW, verapamil may precipitate ventricular tachycardia due to increased conduction across the accessory pathway, because it's kind of there is accessory pathway, so it can create a re-entry tachycardia. So we have to be vigilant about that. So this is just we pass through some of the common drugs. That is not conclusive, so you really need to go back. I have put the reference at the end of this presentation, so you have really need to go and study more about those drugs because they are very important. You will use them commonly, so you have to be really much oriented and familiar with them. During the perioperative period, arrhythmias usually they have a cause. Mitigating the causes of perioperative arrhythmia will reduce their occurrence, and it will reduce your chance of using antiarrhythmic medication. So you have to really diagnose those causes and manage them in a good time to avoid the patient or your patient going into arrhythmia. So sympathetic activity is one of the things, so you really need to avoid that one, especially during laryngoscopy or those kind of things. Severe bradycardia, most of the anesthetic medications is cardiodepressant, so you could get tachycardia very easily. Myocardial ischemia and infarction, so we usually evaluate our patient well. Before the surgery, we evaluate the risk and we explain to them. So the occurrence of arrhythmia will be kind of something expected in some of the patient, and we will be prepared to manage. Electrolyte disturbance, common cause for perioperative arrhythmia, so we need really to mitigate it and manage it appropriately before taking the patient into anesthesia care. Metabolic and respiratory abnormalities, as well as I have just said, intravenous anesthetic agents like cardiodepressant, opioid. We use them most to augment the action of the general anesthetics, but they could also be arrhythmogenic, and they depress the heart. They make bradycardia as well. Anticholinestrases, vasoconstrictors, and drugs which prolong the QT interval. So we have to be all aware of those things which provoke intraoperative arrhythmia. So our knowledge about the physiology of the cardiac action potential and the sinoatrial node, the mechanism of arrhythmogenesis, and the anti-arrhythmic medication. So this all will help us to manage perioperative arrhythmia. So this is a nice sketch. It gives you a clinical tips about the when you encounter perioperative arrhythmia, what you do. Usually there's lots of guidelines And this is it might be incorporated in some of the associations or protocol in relation to ALS or ILS or so. But generally, if you encounter a perioperative arrhythmia, the first thing to think about whether the patient is hemodynamically stable or not. That is the most important because you are treating the patient. So some of the patient, they might have arrhythmia, but they are tolerating well or cardio hemodynamically stable. So the flow of the management will be different. If the patient is unstable, then you have to decide whether they have bradyarrhythmia or tachyarrhythmia, and accordingly, you can treat bradyarrhythmia with kind of uh, anti-muscarinic like atropine, glycopyrrolate, or probably you go further to give beta-1 agonist, adrenaline, or you might need to do pacing, transcutaneous or intravenous, transvenous. Sorry. Tachyarrhythmia, then again, you have to decide whether you need to DC shock the patient, because if the patient is unstable, you might go for that one. If the patient is then stable, then again, you have to decide whether it's bradyarrhythmia or tachyarrhythmia, and then take it from that side. Tachyarrhythmia, then you go into kind of monitoring the patient. If the patient is still start to be compromised in terms of blood pressure, then you go to the other direction. If it is a tachyarrhythmia, then you need to decide whether it's a narrow complex or a broad complex. So you will have an idea whether it is a ventricular tachycardia or supraventricular tachycardia or atrial fibrillation, and then you treat accordingly. Doses of the commonly kind of used antiarrhythmic drugs will differ, but according to the clinical situation. But generally, adenosine, as I said, used traditionally to differentiate between the SVT and VT. You can use it to 6 mg and then repeat to 6 to 12 mg. Amiodarone, as we said, 300 mg loading dose, and then 900 mg over 23 hours. Atropine, as we all know, 600 microgram is a mini jet or sometime in ampule. Digoxin as well, then you need a loading dose, and then you will go for a maintenance. Esmolol, I told it's available. Usually intraoperative is a good friend to use because it kind of dissociate fast, so it doesn't kind of stay or accumulate. Glycopyrrolate, usually it's your friend if the bradycardia is not that much severe, so you could give it a choice compared to atropine. Lidocaine is very good, and it dissociates fast, as we said earlier. It's mainly for ventricular tachycardia. And magnesium is an excellent, it's a cardio stable, and usually we give it at around 1 to 2 grams. And so you have lots of kind of options, but the most important thing is we have to be vigilant and to diagnose in a good time. Okay, we will pass forward, and then we will go to the second part, which is the homeostasis and drugs working on coagulation. So the physiology of the homeostasis is again something very important for us to understand the anticoagulant and antiplatelets medication. Homeostasis is a complex process that maintains blood flow under normal condition, and it prevents excessive blood loss after vascular injury. So homeostasis, it balances the prothrombotic and anticoagulant process to avoid pathological thrombosis. So you don't want excessive bleeding, but at the same time, you don't want kind of pathological thrombosis. So there is kind of elements of homeostasis. So all these all these elements will go to, I just want to highlight there. Sorry. So the endothelial cells have a big role in homeostasis, and usually they promote vasoconstriction to slow down the blood flow and expose the collagen and tissue factor to initiate the clotting cascade. The platelets, usually very important, they form a mechanical plug through the activation, adhesion, aggregation, and secretion. Then the coagulation factors, once they are triggers or stimulated, they are very essential for forming the insoluble fibrin clot. Coagulation inhibitors, they regulate the clot formation to prevent pathological thrombosis. And then at last, the fibrinolysis, it will remove the fibrin clot to restore the blood flow after the incidence has been under control. So it is kind of very tightly controlled between prothrombotic and anticoagulant process. So platelets are very important part of the homeostasis. They are formed from fragmentation of megakaryocytes, and usually they have a lifespan of 7 to 10 days. This is important because when we will come to see about the irreversible blockage of the platelets or with using some drugs, we have to wait for this time to for new platelets to be released in the bloodstream. The function of the platelets circulate between activation, adhesion, aggregation, and secretion. Again, the drugs, antiplatelets, they target those processes to inhibit the function of the platelet. The platelet have lots of receptors from GB1A, von Willebrand factor, fibrinogen, they are all kind of attached to the platelets. And so this is important for us. The implication is mainly those drugs, antiplatelet, they attach to those receptors and do their antiplatelet function. They also target activation and aggregation pathways more than any of the others. Adhesions and secretions are less, but they more target the activation and aggregation. The other part is the coagulation pathway. So you have the platelet and the coagulation factors. And the coagulation pathway is important because it is traditionally the coagulation pathway was classified into extrinsic and intrinsic and the common pathway. So this is the classical differentiation of the model, and it remains useful when you interpret the in vitro coagulation screening. So when we do the test outside the body, this part is very important. However, the classical model does not incorporate the central role that the cell surface play in coagulation. The cell surface play an important role when it is exposed after bleeding or hemorrhage to stimulate the cascade of the coagulation process. So the concept of the cell-based model has been established, the one you can see on the right side, your right side. So this is the classical pathway, while the other is the cell-based model, and it has been created in the sense that to avoid the limitation of the classical model of the coagulation pathway. It's now the most widely accepted model in vivo coagulation. The cell-based model plays a greater importance for the cell surface and interaction between the specific cell surface. And the concept is that the homeostasis is proposed to actually occur in the cell surface. The cell-based proposed that the coagulation process takes place on different cell surface rather than one place, but in different cell surface, and it occurs not as a cascade. The classical model was giving us the concept that the coagulation happened in a cascade, 1, 2, 3, like that. But no, the cell-based model proposed that the coagulation takes place in different cell surface and it occurs as an overlapping stage, which include initiation, amplification, and propagation. So the initiation where the tissue factor activate the clotting factors. The tissue factor in the cell surface, once exposed, it will activate the coagulation factor and it will generate small amount of thrombin. As you can see the diagram, if it is clear. So this is the initiation. So the tissue factor kind of combined with activate factor 7 to activated factor 7, and then it goes to amplification where the platelets provide the surface for further activation of the clotting factor. And then this will be followed by propagation where thrombin generation occurs on activated platelets to stabilize the clot. Okay, so lots of overlapping things happening together rather than a cascade model, which we used to believe about the classical coagulation pathway. So this is again another diagram which kind of showed the action of anticoagulant in terms of the classical pathway. So you have the extrinsic pathway, intrinsic pathway, and the terminal one is actually factor 10. Factor 10, which kind of activate prothrombin to thrombin. So this is kind of the final pathway where most of the anticoagulant drug works. The direct factor 10 inhibitors and heparins as well work in this stage, and they promote the action of the antithrombin to inhibit the production of or the conversion of prothrombin to thrombin. You can see here also dabigatran is a direct thrombin inhibitor, so it inhibits thrombin directly and prevents the conversion of fibrinogen to fibrin. Again, this is kind of a summary of the anticoagulant. We will go to speak about some of them, but this is kind of put most of them together, and it can show you the grouping of those anticoagulant medication. Like we have vitamin K antagonist, which is kind of the commonest example would be warfarin, and then the unfractionated heparins, and this is usually given as an IV, and the more recently used, the low molecular weight, which is kind of given as subcut. And then we have the indirect factor 10 inhibitor, fondaparinux, and the direct factor 10 inhibitors, apixaban, and then the direct thrombin inhibitors, as we just said, represented by the dabigatran. So we have, apart from the unfractionated and the low molecular weight heparin, we have the oral anticoagulants represented by warfarin. This is vitamin K dependent, and the non-vitamin K dependent, which will be the direct thrombin inhibitors like the dabigatran. If we want to say something about warfarin, is a coumarin derivatives and is kind of available for a long time now. It mainly inhibits the epoxide reductase enzyme, and the epoxide reductase enzyme is a very important enzyme, and it is responsible for the cyclical conversion of oxidized vitamin K to a reduced state. So it reduces the oxidized vitamin K, and this is important for synthesis of vitamin K dependent clotting factors, which is 2, 7, 9, and 10. So 1972. So factor 2, which is the prothrombin, factor 7, factor 9, and factor 10. As well, it inhibits the production of protein C and S. They are both kind of anticoagulants. Warfarin is a racemic mixture, or it has two stereoisomers, RNS. The half-life of warfarin is around 36 hours, and it has a very narrow therapeutic index. So we need to monitor the treatment with INR, as we will see shortly. So warfarin is kind of a long-standing drug. You will find most of the patients, they use it. So we need to know about it very well, how to monitor. And obviously it's beyond this presentation, but definitely we need to know how to reverse warfarin therapy in situations of emergency surgery. Monitoring warfarin therapy is very important, as I said, because of the narrow therapeutic index. BT is a measure of the extrinsic system, usually factor 7 and the common pathway. As we said previously, the classical pathway is very important for in vitro testing of coagulation factors. So it's still kind of, it is applicable. So you still really need to know about it. The tissue thromboplastin and the calcium are added to a citrated plasma. INR represents a ratio of the sample prothrombin time to a controlled international standard prothrombin time. So it gives you an INR of a figure. Treatment of warfarin, it depends on the clinical situation, but usually kind of you will say that the cardiologists require the INR to be between such and such for any specific clinical reasons. Heparins, again, is a very important drug, and you will find lots of patients, they will have heparin while they are inpatient, either unfractionated or kind of more recently, most of the patients, they will have the low molecular weight. They inactivate the thrombin, factor 2-8 and factor 10 by enhancing the antithrombin 3 activity. Antithrombin 3 is a naturally occurring antithrombin. So the heparin, they potentiate the effects of antithrombin 3. It combines with thrombin, and inactive antithrombin-thrombin complex is formed. The rate of formation of the complex is increased 1,000-fold with heparin. Okay, heparin also affect platelet aggregation, and they inhibit the platelet aggregation, especially at high concentration. Heparin, they have a very low lipid solubility. They does not cross the blood-brain barrier or the placenta owing to its negative charge. It is highly bound in plasma to antithrombin 3, albumin, protease, and fibrinogen. It's usually metabolized by hepatic heparinase, and products are excreted in urine. Usually the therapeutic dose, something of low molecular weight is 1 mg per kg twice daily. But you find most of the patients, especially hospitalized patients, they will take prophylactic dose, and that has a kind of implication when you give, especially regional anesthesia. So you have to be, again, cautious about that when you plan your anesthesia. The low molecular weight heparins, again, with the same, but usually they facilitate a single daily dose. They have a longer half-life. They have reduced affinity for von Willebrand factor. They are less effective on platelets compared to unfractionated heparin. They have a reduced risk of heparin-induced thrombocytopenia, which is kind of a common side effects of unfractionated heparins. So the need for monitoring is less compared to unfractionated heparin, and they are more effective at inhibiting factor 10. And obviously, as we know, protamine is the reversal agent for heparin, but compared with the unfractionated, they are not fully effective in reversing the effects of low molecular weight heparins compared to unfractionated. For the sake of completion, so fondabrinex is a pentasaccharide that acts as an indirect factor 10 inhibitor. They have a reversible binding to the antithrombin factor to inactivate factor 10. So the inactivation of factor 10 will be usually through the antithrombin 3. The half-life of fondabrinex is around 15 to 17 hours, and activity persists 2 to 4 days after the last dose, especially in a person with normal renal function. So the other group will be the direct inhibitor of factor 10, and this is the rivaroxaban and apixaban. They are very common now. You will find lots of patients taking those medications. They are direct oral anticoagulants. They bind to the active side of factor 10. So they directly inhibit factor 10, and then subsequently they block the final common pathway. They are usually used for venous thromboembolism prophylaxis. They have a short half-life and a rapid onset of action. When compared to warfarin, they have a lower bleeding risk. And then obviously because of their unsimilarity to warfarin has, so you don't need really a routine coagulation test for monitoring, unlike warfarin. So the kind of their use is more simple and easy compared to warfarin, but it's still kind of warfarin with a long safety record for more than 50 years. The direct inhibitor of thrombin is the kind of the dabigatran. Again, you will find lots of patients taking this one. Is a competitive direct thrombin inhibitor. It's a broad drug that's usually rapidly converted to plasma by plasma and liver steresis. Again, it is used in venous thromboembolism and used for prevention of stroke in patients with atrial fibrillation. It has a quick onset of action, and the plasma half-life is around 12 hours. 80% is secreted in the kidney, and you should be cautious or maybe avoid in patients with creatinine clearance less than 30 ml per minute. In terms of antiplatelets, it's kind of, again, another important part of the drugs working on coagulation. And we find lots of patients taking aspirin. Aspirin is one of the non-steroidal anti-inflammatory drugs, and it causes irreversible inhibition of the cyclooxygenase enzyme. Cyclooxygenase enzyme, it has two varieties. It has COX-1 and COX-2. COX-1 usually constitutive, and it's found in the stomach, in renal, while COX-2 usually inducible secondary to inflammation. The action of the cyclooxygenase is important and necessary, and it acts on this arachidonic acid pathway to produce prostaglandins. The prostaglandin H2 is rapidly converted to several bioactive prostanoids, including thromboxane A2. And as we know, thromboxane A2 is a potent vasoconstrictor, and it induces platelet aggregation. Okay, so aspirin has a short half-life, around 3 to 6 hours, and the effects last for the complete lifetime of the platelet. You remember, as we said earlier, all those drugs with irreversible inhibition, we have to wait for new platelet production. So usually platelet function recovery, it will be around 10% per day. Okay, when you interrupt or stop the therapy. We will find most of the patient now, they will go into intraoperative period taking aspirin. So usually it will be continued in the intraoperative period. But as I will mention later, when you manage the intraoperative with the patient, then you have to look to certain things to decide about those drugs. Clopidogrel and prasugrel, they are also antiplatelets, very powerful. They're irreversibly bind to the receptor, B2Y12 receptor, and this is an ADB receptor on the platelets. And this subsequently will prevent the activation of glycoprotein 2 B3A receptor. Both of those medications are broad drugs, and they require hepatic cytochrome B450 to convert into the active form. Usually we load with 300 mg followed by a maintenance dose of 75 milligram. And antiplatelets effects are seen immediately within 2 hours. They are very powerful drugs. Clopidogrel dose of 75 mg per day usually produce 60% decrease in the platelet function. So you have to know that it's a platelet function, not platelet number. The number might be normal, but still the function is depleted based on the previous slide when we mentioned about the platelet function, the aggregation, the activation, the secretions. So these kind of things will be activated, but you might find the platelet count is normal. But due to irreversible mechanism action, so it is usually the therapy will be interrupted for 5 to 7 days before non-cardiac elective surgery. But this is kind of very, it will be based on the guidelines of based on different type of surgery or type of indication for the use of clopidogrel or Blavix. Lots of people, so you have to be very vigilant about Blavix. Another non-thiopyridines is ticagrel and cangrel. So these are both kind of reversible, non-competitive B2Y12 receptor antagonist. They bind to those ones and they reduce the platelet activity. Usually they are very quick within 2 hours, and cangrelin maybe within 2 minutes of administration because it's given intravenously. So again, recommendation will be, again, according to the guideline, as I said, but usually you will stop or suspend them maybe 5 to 7 days before elective surgery. Abciximab is a monoclonal antibody. It inhibits platelet glycopyrrolate 2B3A receptor and block the final common pathway of platelet aggregation. So it inhibits over 80% of ADB-induced platelet aggregation and thrombin generation. It's an intravenous, and usually it is used concurrently with unfractionated heparin to control the ABTT, activated prothrombin time, and activated clotting time. It again may be similar to heparin. It might induce thrombocytopenia. Okay, an important part which I wouldn't elaborate much on those ones, but the clotting test is a very important part, and you need really to know about it. The standard clotting test, the prothrombin time, this is just kind of a quick idea about it, but you need to know more about them. Prothrombin time, I mean to link them to the clotting factors and the anticoagulant as well. So which is which? So prothrombin time, measure the time taken for clot formation when tissue factor, thromboplastin, and calcium are added to platelet depleted plasma. Okay, so you remove the effect of the platelet, and so you put this one in vitro. So this time will be mentioned or taken as a prothrombin time. And it give an indication about the activity of the extrinsic and the common pathway. Okay, so those factors 2, 5, 10, and activated factor to the prothrombin and the fibrinogen. So these all will prothrombin time will give indication about those factors. While the thrombin time is assesses the conversion of fibrinogen to fibrin, and is measured simply by adding exogenous thrombin to platelet depleted plasma. ABTT, this measures the time taken for the clot formation in platelet poor plasma after the addition of phospholipid. And it's affected by abnormalities of intrinsic pathway. So factor 12, factor 11, 8, 9, and the common pathway factor 5, 10, and 2, which is the prothrombin and the fibrinogen. Fibrinogen levels also are very important, especially in the intraoperative setting. You need to know the fibrinogen level, and you might need to give fibrinogen replacement. So when it comes to management of the intraoperative anticoagulation, obviously I didn't elaborate on this, and this might be kind of a separate tutorial, but you usually assess few things to manage. It's kind of a comprehensive kind of approach to the patient. It can go from risk assessment. You have to evaluate both thromboembolic risk and surgical bleeding risk. And this will be based mainly on the type of the surgery, whether the bleeding risk is high or low, and then the type of the patient also, whether the anticoagulation indication, whether it's a valve or it is an atrial fibrillation, or so all these kind of things you have to evaluate before you decide about stopping anticoagulation, bridging anticoagulation, or continuing anticoagulation. So you have to have a multidisciplinary approach that will be involving physicians like cardiologists, surgeons, and obviously hematologists as well. So because you have to decide really what you will do with those anticoagulants. Again, guidelines are very important, and guidelines sometimes kind of differ from place to place, from kind of society to another, but generally there is kind of broad lines about the guidelines, especially in regional anesthesia. And when you want to institute an epidural or a spinal or a nerve block, then there is some certain guidelines you have to follow. So I kind of advise or recommend kind of these three approaches. So you have to assess the risk, you have to have a multidisciplinary approach, and then you have to refer to the guideline to decide about what you do about the anticoagulant or antiplatelets your patient is currently taking. Okay, sorry. So it's kind of it's a big topic. So definitely this is just to highlight. You need really to read about it more. But it highlight the points that if you are doing exam, what you concentrate on. It kind of definitely, if you augment it with a further reading, it will definitely help you about your clinical judgment and management of your patient. However, I would say that most of the perioperative arrhythmias, they do not require treatment with antiarrhythmic drugs. So you have really to pick up the cause. You have to mitigate those risks. You have to manage your patient very well. If it's an elective case, then you have to kind of optimize your patient very well prior to the surgery. You have to have an anesthetic approach which minimize the occurrence of arrhythmia, and so that's all will keep your patient safe. So most of the time, you really aim to correct those causes before the surgery. Many of our drugs we use in anesthesia, they are unfortunately potentially arrhythmogenic, so you have to be cautious of that one. The second part of the presentation, I would say that the anticoagulation therapy is most commonly indicated in the presence of atrial fibrillation, DVT, pulmonary embolism, and after placement of prosthetic heart valve. So all, if you have a patient who have one of those things, that will kind of, because most of the patients sometimes they don't say this is kind of, they don't maybe think there's something serious they need to say, but you have to dig in the history to know whether they are taking anticoagulant or antiplatelets. Optimal management of anticoagulation is achieved through a balance between the thromboembolic and bleeding risk. As I previously said, that you have to have a risk assessment to see what type of the surgery the patient is going and why they are taking anticoagulant or antiplatelet for one reason, and whether stopping those medication, like kind of risk and benefit, whether stopping the medication will be good or bad for the patient, whether you need bridging. Bridging also is very questionable now. Most of the cardiologists probably they don't like bridging. So whether you go with those anticoagulant to the intraoperative period or you stop them before. So it's kind of a multidisciplinary approach. Thank you very much.
Thank you, yeah, Osman. Very comprehensive talk. I think you managed to shed the light on the important aspects of each parts of the topic that you have topics that you have discussed today. I just want to draw the attention of our colleagues that there is European and American guidelines when it comes to neuroaxial management of anticoagulated patients. You have to just follow the policy or the guidelines that your institution or your facility follow. So adhere to that. And I think the difference is marginal in terms of time duration for interventions. Any questions for Dr. Osman before we wrap it up? جماعة التوبكس المهمة دي ما عندكم أسئلة؟ طيب السؤال الأول يا عثمان قال لك in patients with history of hits for cardiac surgery or need anticoagulation, the guideline to use for is guideline to use heparin again or another anticoagulant specifically for cardiac surgery. Okay. Patient عنده history of hits. That's what I gather from the question.
Yeah.
And he needed anticoagulation. Will you opt for heparin with that background, yeah, Osman?
Yeah,
Or no?
as far as I know, you don't. So you have to really have a multidisciplinary approach for such patient to see. Obviously, this kind of patients will be highlighted early that they have hits because it is an autoimmune, um, and then probably you need to look for guidelines for that one.
Yeah.
I don't really have a right or wrong answer at the moment, but I could look to that one and see.
Yeah, I think many factors, yeah, Doctor, يعني will be controlling the situation here. So how urgent is the surgery? So that the time is a factor here. Whether you need something for urgent anticoagulation or you still have a time the severity of the condition that the patient had. I think the in these cases, especially if the patient or the surgery were high risk, usually having an expert in the panel, as Dr. Osman correctly pointed out, having a hematologist is very important to direct the management. This is what we usually do.
Yeah, but the most important also to do the test to confirm that is hits. So because diagnosing hits is not something easy, and if it is confirmed, then
Mm.
you will really need to use non-heparin anticoagulant. There is lots of them, so it's not difficult because it's an antibody mediated condition. And there will be antibodies against the platelet factor. So you will really need to avoid heparin.
Intraoperatively, I think, yeah, Doctor, you can unmute. Um, I think he meant intraoperatively, Osman, when they ask to inject heparin, because this is
Mm.
the common use medication.
Mm.
So mostly intraoperatively, you inject and reverse. So you have come across cases where they inject other medication, for example, for bypass, for all this.
Yeah.
It's a tricky
Things
situation,
like
I'm sure.
ergotropan and
Uh,
valorudine, this will
okay.
be used in cases of hits because obviously you
Mm,
cannot give them heparin. Well, like I
okay.
haven't come across a patient with hits in this scenario, but yeah, it can happen.
Can,
Uh,
yeah.
but once it is confirmed, then you definitely need to avoid heparin, and then you will use non-heparin.
You will use an alternative like that. I remember we used to encounter it mostly in ICU setting, and
Yeah,
we used to go for dabigatran or other medications.
yeah.
If I remember
Even
correctly, that was
ergotropan is available, so it's usually used as a non-heparin uh,
yeah.
medication because you will need it in cardiac surgery.
Okay. Any other question? أنا عايزة أخد your opinion يا عثمان في الليبرال يوز بتاع tranexamic acid.
Mm,
Most of the surgeons, they love it. They think it's a magic drug that it can stop any intraoperative bleeding.
yeah,
Especially in our cohort, طبعا they are thrombogenic by nature, like, so like being liberal with tranexamic acid, I think it's not the best approach.
mm,
However, like, to convince the surgeons, يا خالد لو سامعنا, it's not an always easy battle to win. What do you think about this? Do you usually have a low threshold to give it, يعني ولا لا?
In orthopedic surgery, yes, because there is a clear evidence that it reduced the bleeding without increasing the thrombotic risk. In obstetric, I haven't come across a study in terms of evidence,
Mm.
but
There is
I
the women's study. I mean, like when it's indicated,
mm,
it's like, it can make a difference even in mortality, but just the
mm,
liberal use of it, I think it just for
yeah,
me, it's a bit question. So, as you correctly said, in some type of surgeries, the evidence are really high, but not for any intraoperative bleed.
yeah,
Do,
intraoperative
do
in
you face
obstetric, I'm
this
not sure,
problem? Okay.
but post-operative, it is postpartum hemorrhage. Yeah, I think it is included in
Yeah.
some of the guidelines, but
Yeah. Yeah.
intraoperative bleed, I haven't come across.
Not bleed. I mean, like with bleeding, frank bleeding, I personally would have a low threshold to go for it.
Mm, mm,
But however, but I think the surgeons usually they usually ask whenever there is oozing in the field or anything, they usually
mm,
ask for it regardless of the
mm,
background of the patient.
mm.
So this is another, honestly, one of the obstacles that I encounter empirically in trauma cases
Yeah,
and in total knee replacement.
yeah, I know.
The mainstay, yeah, yeah. Otherwise, a rotem when available.
Mm,
مم. طبعا يا أورتيغا الروتم ده we use it yeah when the patients are when the patient is bleeding يعني فالإمبيريك يعني أنا ما فهمت التعليق لكن هاي في certain surgeries الإيفيدنس بتاع إنك تدي ترانكزاميك أسيد فيها very high.
yeah.
Rotem, definitely, it's a point of care test that can guide you when you have a bleeding, and it tells you why the patient is bleed, but it doesn't tell you if the patient is going to bleed or not.
Yeah. But
This is يعني my take on it.
yeah, I think in postpartum hemorrhage, yeah, there is some kind. You will find some recommendations in some of the
Yeah, yeah.
societies, but intraoperative bleeding, I don't know really.
تمام.
To,
Should
to be
we wrap
honest,
it up?
to be honest بالنسبة للسيرجن's perspective
Uh-huh.
أنا at a personal level intraoperative الصراحة I didn't come across using it بالعكس بنكون very cautious
Mm,
especially في الهيباتوبيلر والليفر ترانسبلانت والحاجات دي.
okay.
لكن بوست اوب لما يكون عندك minute bleeding that keeps on مثلا مريض لاب كولي كان في اوز من البيد وبعد العملية خدت درين ولسه بيطلع بلود اون ان اوف اون ان اوف. صراحة
Mm,
يعني حسب خبرتنا البسيطة فيه انه it has it does do the job يعني بيوقف لك
mm,
البسيط يعني هو الثيوري اللي عموما نحن بنشتغل بها اذا هو البليدنج او حاجة من السمول فيزلز او
mm,
capillaries it's good. لكن في الحاجات
mm,
الكبيرة الصراحة would prefer just to go ahead and fix it rather than give it وبعدين الريسك بتاع الثرومبوزيس منه. فدي كلها حاجات بنكون شوية كده conservative في إننا نستعمله يعني بصورة كبيرة يعني. حتى في ناس الصراحة ما بيحبوا أصلا يستعملوا ترانكزاميك أسيد regardless بيقول لك يا أخي وقفوا وقف الانتي
mm.
كواجولانت لو بتديه واستنى لو ما هنا just go ahead and fix it يعني take العيان لمريض for a second surgery and fix the bleeding. المشكلة طبعا معظم الأحيان بتدخل ما بتلقى source of bleeding لأنه معظم الأحيان بيكون حاجة بسيطة trivial وحصل لك كلوت في الحتة بتاعته وعملت tamponading effect ووقفت. فعشان كده بنكون بالذات في الهاي ريسك بيشنتس ترانكزاميك أسيد يمكن يكون بيحل لك المشكلة بتاعت الدايليما دي. فده من ناحيتنا.
Yeah,
Sure.
On a second
true.
note أنا I would like to thank دكتورة حياة دكتور عثمان طبعا يعني الصراحة السيشن very valuable very very valuable يعني it touched two important topics اللي هم الانتي اريثميكس والانتي كواجولانس حاجات بنلاقيها في الديلي لايفز. ودكتور حياة ودكتور سهيل ودكتور ايناس طبعا على تنظيم المحاضرات دي وخصوصا ان احنا خلاص في نهاية فيز 1 وزي ما قال الدكتور حياة هنشوف فيز 2 والامور اللي هنا طبعا will be taken over by the new people الجايين. فشكرا لك دكتور حياة وشكرا دكتور عثمان مرة تانية كتر خيركم كتير. شكرا طبعا للشباب برضه على وقتهم والمشاركات اللي هي بتخلي السيشن فعلا فاليبل يعني الأسئلة سؤال مع إنه بسيط بتاع دكتور فتحي لكن الدسكشن اللي حصل
جرى
فيه
كمية النقاش الجا كبير بعد ذاك.
aspects. فشكرا لكم كتير.
Thank you.
شكرا خالد، شكرا
شكرا
جزيلا.
لكم.
Thank you. شكرا. I think we can wrap it up now. شكرا دكتور
دكتور حياة
عثمان. شكرا دكتور خالد. I think we can stop the recording here. شكرا جزيلا.